Hello friends, welcome to this FMG flashback session for pediatrics. A very good evening to all of you. I hope I am visible, my screen is visible and I am audible. Please confirm so that we can begin. Can't see, Shubham says can't see. Can anyone else please confirm if my screen is visible and I am audible? Waiting for your reply, dear. Good evening, Parveen, Mukesh, Abhishek. So are you able to see my screen? Thanks, Sultan. Thanks, Hanuman. Okay. So a very good evening once again to all of you. So in this session over the next 1 hour or so, we will quickly revise all the pediatrics questions, the most important topics that have come in the last 5 years in your FMG exam. Okay. So be with me for the entire 1 hour, and I'm sure you'll be able to answer most of the questions that come from pediatrics in your upcoming exams. Okay. So this is going to be a revision session. So I want it to be interactive, as much as participation from your side as possible. Okay. So here we begin. So what does the following growth chart represent? So I hope you can see this growth chart where there is you can see this curve. So this curve is showing that there is increase. There is an exponential increase in some growth after around 10 to 11 years of age. Before that, it is relatively stagnant. So what does this following growth chart represent? Does it represent gonadal growth, lymphoid growth, brain growth, or stature growth? Let us see who all can answer it correctly. Yes, so something which does not grow so much in the first 10 years of life, and then you can see that around 10 to 11 years of your life, suddenly the growth increases a lot. So what is that growth? So very good, I can see most of you are answering correctly. Mehta, Shubham, S. Khan, Ifshan, Jas, Ashfaq, Vishwas. So it is, yes, gonadal growth. So gonadal growth, it begins during the adolescent period, right? So before that, it kind of grows very, very slowly, and during puberty, what happens? There is an exponential increase in the size of gonads, in the development of gonads, and we know the SMR staging or the Tanner staging which is used. Okay, right. So these are some different patterns of growth that we can see. So once you've got the question on gonadal growth, but we can get questions on other types of growth as well. Okay. So what does this first chart represent? So here what you can see is maximum growth happens in the first 2 years of life, and thereafter not much growth is happening. So if you get a graph like this signifies brain growth. So we know the maximum increase in the size of the head or the brain happens in the first 2 years of life. Thereafter, the rate of growth slows down and does not increase much. Good evening, MedPsycho. Yes, brain, very good. So what do you see in the next graph, which I am showing you in purple? So here there is accelerated phase of growth in the first year of life, and then the growth kind of slows down, and then again the growth increases during the puberty. So this is what is the somatic growth, or the growth in height or stature. Okay, somatic growth or the growth in height or stature. So we know in the first year of life, when a newborn is born, how much is the length of the baby? It is 50 centimeters. At the end of 1 year, it becomes 75 centimeters. So there is an increase of 25 centimeters in the first year. Thereafter, the rate of growth slows down, and then again during puberty, there is a pubertal growth spurt. Okay, so this is somatic growth or the increase in height or stature. Now, what do you see in the next graph, which I am showing you in green? So this is a graph where you can see that there is a peak growth in between the age group of say around 4 to 8 years. Okay, 4 to 8 or 9 years. So 4 to 8 or 9 years, the growth increases, and before that and after that it is not so much. So this graph shows, very good, Mehta, Sultan. So this is lymphatic growth, okay, or lymphoid growth. So the growth of lymphoid tissue. So if around 5 to 6 years of age, you're getting a case scenario where a child comes with tonsillar enlargement, but the child has no fever, the tonsils are not red and congested, then be sure it is absolutely normal, because this is a phase of time when you can get a lymphoid hypertrophy, which is physiological. Okay, and what you see in this graph we already discussed. So this is the gonadal growth. So gonadal growth is predominantly happening after puberty has set in. Okay, so this is the gonadal growth. So I am sure you are clear with any of these growth patterns which can come now. Right, very good. So moving ahead to our next question. So here we have a 7-year-old boy who presents with short stature. So we know short stature is height of a child less than third percentile or less than -2 standard deviations or Z score of expected according to the age and sex. Okay. So each question that we are discussing a lot of important things related to it. Also, we are having a quick revision so that you can answer all the questions that come related to it, right? So his weight is appropriate as per his age. His bone age, however, is less than the chronological age. Okay. The height of his parents is normal. That is another important information that we have. What is the diagnosis? So is it constitutional short stature, familial short stature, cretinism, or malnutrition? So very good. Proud of you guys. So Ahmar, Ashfaq, Hitesh, Mehta, Jheel, S. Khan, Shubham, Sonu. Awesome. So it is constitutional short stature. Why do I say so? Because one is that this child doesn't appear to be malnourished. His weight for age is appropriate. His bone age is less than the chronological age, which is a feature of constitutional delay in growth and puberty. Okay, so constitutional short stature is also known as CDGP, that is constitutional delay in growth and puberty, where there is delay in skeletal maturation. So bone age will be less than chronological age. So it is also called constitutional delay in growth and puberty, right? Now the height of his parents is normal. So if the height of his parents is normal, this will rule out familial short stature. It cannot be familial short stature because the parents are not short. Okay. Cretinism, again, we will not think because we have not been given any other clinical features like the child has developmental delay or intellectual disability or his weight is more, he's obese child. We don't have any other features of hypothyroidism. So we are not thinking of cretinism. We are not thinking of malnutrition either because his weight is appropriate for his age. Okay. So most of you will be able to, pinpoint that this is the correct answer, constitutional short stature. If you're not able to, then try to exclude the options also one by one. That will lead you to the correct answer, right? So moving ahead, which is the first tooth to appear in a child? Is it the lower central incisor, first molar, upper central incisor, or canine? Yes, waiting for your answers. Come on. So first tooth to appear in a child. So if nothing is mentioned, first tooth means the first milk tooth or first tooth in the primary dentition. So very good. Amandeep, Mukesh, Hitesh, Karishma, Shubham, Kamal, Rudra, Love, Heal, Grow. Nice name. Parul, Goyal, Ajay, Mubarak. Okay. So it is the lower central incisor. It is the first tooth to appear in a child. It is the first tooth to erupt in primary dentition. Now we can get questions related to it. Primary dentition is also known as milk teeth. Okay. Milk teeth or temporary teeth. Right? Secondary dentition is also known as the permanent teeth. Permanent teeth. So we all know when does the first milk tooth appear? So it appears at around 6 to 7 months of age, while the first permanent tooth appears. First permanent tooth appears at the age of 6 years. So be very, very sure what the question is trying to answer. When does the first tooth appear or when does the first permanent tooth appear? The answer will entirely change, right? First tooth. Which is the first tooth to appear? We already saw it is the lower central incisor. Lower central incisor. And which is the first tooth in secondary dentition? Or if your question asks which is the first permanent tooth to appear, then what will be your answer? Yes? So first permanent tooth to appear. Okay? First permanent tooth. If the question was first permanent tooth to appear, what will be your answer be? Very good. LMS Biochem classes. Abhishek Mishra, Parul, Amandeep. So it will be the first molar. Okay? Now the last tooth to appear in primary dentition is the second molar. The last tooth to appear in secondary dentition is the third molar or the wisdom tooth, which might not erupt in some of us also, right? Now when does the primary dentition complete? It usually completes by 2.5 to 3 years of age. While secondary dentition completes by around 12 years of age, except the third molar which comes anywhere between 18 to 25 years of age or may even come later in life. May not come in some also, right? Total number of teeth in primary dentition. Come on. So total number of milk teeth that a child can have is 20. While total number of permanent teeth that the child can have will be 28 to 32 depending on how many third molars of wisdom tooth the child has. That has nothing to do, of course, with the wisdom of the child. Right. So moving ahead to our next question. Again, a very simple one which was asked in 2019. What is the number of primary teeth in a 3-year-old child? So we all get it. Primary tooth or milk tooth in a 3-year-old child number, whether it is 20, 24, 16, 32. Come on. So yes, Rahula, Aditya, Priyanka, very good. So it is 20. Very good. So which of the following statements are true? So first hand to hand transfer appears. Hand to hand transfer appears, then palmar reflex disappears. First palmar reflex disappears, then hand to hand transfer appears. Both palmar reflex and hand to hand transfer appear at the same time. Both disappear at the same time. So the options are very confusing, but the question is pretty simple. Yes. So what is the correct answer? So very good, guys. Atif, Vikrant, Amandeep, Parveen, Aditya, Priyanka, Pradyuman. So it is first palmar reflex disappears, then hand to hand transfer appears. We know that certain primitive reflexes will disappear, then the child will learn to do certain things. So what are some rules of development? So of course the development depends on neurological status of a child. So if the child has cerebral palsy or any other neurological problem, then the development will not happen normally. Okay, so depends on neurological status of the child. Okay, neurological status of child, and the development happens in cephalocaudal direction. What does that mean? First neck control will come, then the child will learn to sit, then the child will learn to stand. So it happens in cephalocaudal direction. Okay, and what else? So truncal tone develops first, or truncal development happens first, followed by the limbs or extremities. So truncal development happens first, followed by the extremities, right? And what else? Certain primitive reflexes disappears, then the child learns to do something. Okay, so primitive reflex disappears and some developmental milestones will appear. Okay, so milestones appear, like for example, we said when the palmar grasp reflex disappears, then the child will learn to voluntarily grasp objects. Similarly, when the ATNR or asymmetric tonic neck reflex disappears, then the child will learn to roll over from prone to supine or supine to prone. Okay, so the sequence of attainment of developmental milestones usually remains the same, irrespective of whether the milestones are coming later or at normal time. Okay, so some important primitive neonatal reflexes about which we get questions. So there are reflexes which are present at birth. Okay, reflexes present at birth. So important reflexes which are present at birth, what are they? We all know. So one is the rooting reflex. What is rooting reflex? You stimulate near the angle of mouth, baby will open the mouth and turn the mouth to that side to breastfeed. It appears by around 35 weeks gestation, disappears by 1 month postnatal age. Okay. Morose reflex, a very, very important reflex. And number of times you've got questions on asymmetric Morose reflex. When can you see asymmetric Morose reflex? Like in fracture clavicle, shoulder joint dislocation, Erb's palsy, and so on. So Morose reflex begins to appear 28 weeks, completely appears by 37 weeks, disappears by 5 to 6 months. Okay. Abnormal persistence of Morose reflex beyond this time indicates cerebral damage. So all these are separate questions in itself. Okay. Then you have a palmar grasp reflex, which we already mentioned. So palmar grasp reflex appears by around 28 weeks of gestation, disappears by 3 months postnatal age. And there is another ATNR or asymmetric tonic neck reflex, appears at around 35 weeks gestation, disappears by 5 to 6 months. Only when this reflex will disappear, baby will learn to roll over from prone to supine, supine to prone. Now, among the reflexes appearing after birth, so these were the reflexes present at birth in a term baby. So, reflexes appearing after birth. The most important one is the parachute reflex. Okay, the most important one is the parachute reflex. So, parachute reflex is important because it comes around 7 to 8 months of age and it never disappears. It persists throughout life, making it very important, right? So moving ahead to the next question. When does handedness get established? So when will you come to know whether a child is a right-handed guy or a left-handed guy? So when does handedness get established? Come on. 6 to 12 months, 15 to 18 months, 18 to 24, 36 to 40. Rapid fire. Yes. Waiting for your answers. Very good, Nigar. Very good. So 36 to 40 months is the time when the handedness will get established. So let us quickly revise some of the most important milestones. Okay, so the neck control usually appears by 3 months of age, and partial neck control by 3 months, complete neck control by around 5 months. Then sitting, standing, walking. With support first, without support later. So sitting with support 6 months, without support 8 months. Standing with support 9 months, without support 12 months. Creeping comes in between, so 10 to 11 months. Walking with support again comes at around 12 months of age, walking without support 13 months. And riding a tricycle, friends, is a very important milestone. Tricycle has got 3 wheels, riding a tricycle at 3 years of age. Okay, no mistake on that. So moving ahead to some important fine motor milestones, a quick revision. Hand regard. Hand regard means bringing the hands to midline as if examining his or her own hands. So hand regard comes at around 3 months of age. Okay. Bidextrous grasp, holding with both hands, around 5 months. Palmar grasp or unidextrous grasp comes at 6 months of age. Transfers objects from one hand to another at 7 months. Immature pincer grasp comes at 9 months. Mature pincer grasp at 12 months. Scribbling spontaneously like this, say at 15 months. Tower of 6 to 7 cubes, 2 years. So, number of cubes put in tower is age into 3. So, 2 years, tower of 6 cubes. 3 years, tower of 3 threes are 9 cubes. Okay. Handedness appears at around 2 years, while handedness gets established by 3 years or 36 months. And that is our answer here. Right. Moving ahead to the drawing skills of a child. Very, very simple, but very, very important. So, a line has got two ends, right? So, drawing a straight line or copying a straight line comes at 2 years. Now, 3 has got these circular things in its picture. So, drawing or copying a circle comes at 3 years. A rectangle has got 4 vertices, okay? So, copying a rectangle at 4 years. Triangle, drawing oblique lines is more difficult for the child, so at 5 years. And copying a diamond comes at 6 years, right? Moving ahead to some social milestones, the most important one, social smile comes at around 2 months of age. Mirror play, the child smiles at his own mirror image around 6 months. Stranger anxiety 7 months. Waves by 9 months. Plays peekaboo. So peekaboo around 10 months of age, plays a simple ball game 12 months. Points to objects 15 months. Domestic mimicry and dry during daytime 18 months. Parallel play, that means if you make 2-3 children sit near each other, they will play on their own, not play with each other. That is parallel play, comes at 2 years and joins in play at 3 years, right? So moving to the language milestones, a child vocalizes, that means produces any sound. So vocalizes at 2 months, a more musical sound at 3 months. Monosyllabic babbling 6 months, bisyllabic babbling 9 months. At 1 year, a child is able to say 2 to 3 words with meaning, okay? Now, thereafter, the number of words put in sentences is equal to age in years. So, 2-word sentences, 2 years. 3-word sentences, 3 years. Now, what is this jargon speech? Jargon speech means the child has his own name for certain objects. Like many North Indian children call water as mum. So, every time for water, he will say mum. So, that comes around 15 months. And at 18 months, the child has a vocabulary of 10 words. Right? So, these were some very, very important milestones that we need to remember. Moving ahead to another very simple question. So, the questions from pediatrics in FMGE have been pretty simple. So, it is a very, very scoring subject for you. So, just let us go quickly through these questions and I'm sure you're going to ace it. Okay. So, within how many hours can breastfeeding be initiated? So, within how many hours can breastfeeding be initiated in a perfectly healthy child with no anatomical problems? So, what is recommended? So, breastfeeding should be initiated as soon as possible. Irrespective of whether it is a vaginal delivery or cesarean section, the current recommendation is, yes, waiting for your answers, Nitin, very good, Zomboni, SS, Hitesh, very good. So, as soon as possible is the best option if that is there. If that is not there, it should be started within 1 hour of birth, irrespective of whether it is a cesarean section or a vaginal delivery, right? Breastfeeding should be continued for minimum how many months? So, exclusive breastfeeding would have been a better question. So, exclusive breastfeeding should be continued for a minimum of, yes, we all know. So, Mr. Raj says 6 months. So, previously, different cutoffs were there. Cesarean section, you have to start within 4 hours, vaginal delivery, half an hour, nothing like that, 1 hour. Breastfeeding should start within 1 hour of childbirth and exclusive breastfeeding should continue till 6 months of age. Nothing else should be given, not even sips of water unless medically indicated. Okay. Now, what is an absolute contraindication to breast milk or breastfeeding? Is it galactosemia in the infant or maternal hepatitis C, maternal CMV, herpes not involving the breast? So, absolute contraindication to breastfeeding. So, we all know all babies should be breastfed, but there are very few handful of conditions when you will not breastfeed the baby. So, very good, Nivedita, Faz. So, you guys are really rocking. Paveen, Doc, Nitin, Nidhi. So, very good. So, all of you are right. Yes, it is galactosemia in the infant because we all know why. So, milk, breast milk or any form of milk will contain lactose and lactose breaks down to glucose and galactose. And in galactosemia, this galactose is not digested by the baby. So, hence the problem. Right? So, contraindications to breastfeeding can be related to the baby, can be related to the mother. Related to the baby can be conditions like confirmed case of galactosemia. If the baby is confirmed case of galactosemia or if the baby has congenital lactose intolerance. Okay. Lactose intolerance, again, the baby will not be able to digest lactose, right? Absolute contraindications related to the mother is when, if the mother is on radiotherapy or chemotherapy, then you will not breastfeed the baby. Okay. And relative contraindications are some infective conditions in the mother. So infections in the mother, like maternal active untreated TB, then maternal herpes or varicella lesions involving the breast area, maternal HIV. So these are some relative contraindications where you may or may not breastfeed depending on the exact situation, right? So all are true about human colostrum except, so we all know colostrum is the thick yellowish milk that comes initially in the first 72 hours after birth. Now colostrum is so rich in nutrients that it is in fact known as the first immunization of the baby, because it contains macrophages, immunoglobulins. Okay, so it is called the first immunization of the baby. So all of the following are true about colostrum except. So let us see the answers. So whether it is thick and yellow, IgA high, high amino acids and minerals, and high sugar and fat. So very good, Aisha, Vikrant, Faiz, Nausheen, Vikash, Harshit, Miss Estrogen, nice name, Ajay, Nitin. Okay. So high sugar and fat. So colostrum does not contain high sugar. In fact, colostrum is not very tasty for the baby, but it is very, very beneficial for the baby because it contains a lot of immunoglobulins, macrophages, and is called the first immunization of the baby. It is thick and yellow in color, IgA levels are high, and it has a lot of amino acids and minerals. So colostrum should always be fed to the baby, and no prelacteal feed should be given, right? So a little bit about the composition of breast milk versus cow milk. We get a lot of questions related to it. Okay, so true, all of the following are true about breast milk except, or false about breast milk. So you need to know a little bit about the composition. Okay, so the carbohydrate content in breast milk is around 7 gram per dl as compared to 4.5 gram per dl in cow's milk. So breast milk has more carbohydrate as compared to cow's milk. So it gives more energy as carbohydrate to the baby. Breast milk has more lactose. Okay, it is sweeter. Now proteins. So breast milk has got lesser protein than cow's milk. So protein in breast milk is around 1 gram per dl versus 3.5 gram per dl in cow's milk. So it poses lesser solute load to the developing kidneys. So 1 gram per dl of protein is perfectly suitable for the baby. Not only this, the breast milk is richer in whey proteins like lactalbumin, lactoglobulin, so whey proteins which are more easily absorbable by the baby. And it contains adequate amounts of amino acids like cysteine, taurine, methionine, which are required for the CNS development of the baby, right? So about the lipids. So about the lipids, breast milk is richer in PUFA, polyunsaturated fatty acid, and it contains adequate amount of DHA or docosahexaenoic acid, which is required for the CNS development of the baby, while cow's milk has less of these. Now minerals, iron content of breast milk is poor, but the iron present in breast milk is more easily absorbable. Okay, more easily absorbable, though breast milk is poor in iron. And cow's milk is also poor in iron, but iron present in breast milk is more easily absorbable. And the calcium phosphate ratio of breast milk is such that calcium is easily absorbed. Okay, so calcium phosphate ratio favors calcium absorption in breast milk. Okay, while cow's milk is richer in phosphate. Cow's milk has got more phosphate. So what will happen? More chances of hypocalcemia. So if a child is predominantly cow milk fed, the baby will have more of hypocalcemia. Okay, calcium deficiency. Now very, very important question, n number of times it has come. So the breast milk contains adequate amounts of all the vitamins except, which are those? Vitamin D, vitamin K, and vitamin B12 in strictly vegan mothers. Okay, B12 in strictly vegan mothers. Okay, right. Now cow's milk we know is deficient in vitamin C. So cow milk fed babies have more chances of scurvy. Okay, right. Nutrient deficient in breast milk is, again we all know, vitamin A, B, C, D, which is the answer here. So because vitamin D and K are deficient in breast milk, vitamin D supplementation is required throughout first year of life in all infants. And vitamin K single dose intramuscular is given to all babies at birth. So vitamin D is the answer here. Very good, guys. So the next question, which came in June 2022. So pearly white lesions with foamy appearance are seen on the sclera of a child. So we can see this pearly white lesion here. Okay, and it is triangular in shape, right? which of the following other symptoms are related to the deficiency of same micronutrient? So what we see in this picture, what is it? So what is the lesion? Very good, Shan. So it is Bitot spot. So Bitot spots we know are a feature of vitamin A deficiency. So vitamin A deficiency will also cause which of these? Conjunctival cirrhosis, angular stomatitis, glossitis, photosensitive rash. So it is very good. Nivedita, Nahid, Navrang, Nidhi, Ayaz. So it is conjunctival cirrhosis. In fact, conjunctival cirrhosis is the first sign of vitamin A deficiency in children. Okay. So vitamin A deficiency, we all know there is a WHO grading. I'm not going to details. You must have studied in ophthalmology as well as PSM. So XN is night blindness, X1A is conjunctival cirrhosis. That is the earliest. So this is the earliest sign of vitamin A deficiency, while night blindness is the earliest symptom of vitamin A deficiency. So you can get a case scenario where a child is not able to see clearly at night. Think of vitamin A deficiency. And then you have Bitot spots, corneal cirrhosis, corneal ulceration, and finally scarring. Okay. Now, this question has also come multiple times. What is the dose of vitamin A which is used for the treatment of vitamin A deficiency? So less than 6 months, then the oral dose would be 50,000 units per dose. Okay, 6 to 12 months, each dose will be 1 lakh international units per dose. Okay, and more than 1 year, the dose is going to be 2 lakh international units. So if you are giving it for treatment, you have to give it at diagnosis, repeat it 24 hours later, and you have to repeat a dose 2 to 4 weeks later. Okay. Now, so again, this question you can see has come in January 2023 also, December 2021 also. So 8-month-old child was found to have features of vitamin A deficiency. What is the dose? So for 8 months, what will be the dose? We just discussed. So less than 6 months, we discussed it is 50,000. For 8 months, what is going to be the dose? Very good, Mukesh, Mehta, Urmil, Sharik, Parveen, Nausheen. So it is 1 lakh international units. Okay. Now, which nutrient deficiency can cause collagen defect? Is it A, B complex, C or D? So we already discussed that cow's milk is deficient in this vitamin, and cow milk fed babies have more chances of, very good, Priyanka, Mubarak, Rahul, Hitesh. So it is vitamin C. So vitamin C is deficient in cow's milk, and moreover it is a heat labile vitamin. So you boil the cow milk also, vitamin C further decreases. So cow milk fed babies have more chances of scurvy. So this vitamin C deficiency is going to cause scurvy. Now scurvy is seen, and what happens in scurvy? Because vitamin C is required for collagen synthesis. So if vitamin C is deficient, collagen is not synthesized properly. And collagen is the backbone of blood vessels. So blood vessels are fragile. So you have gum bleeding, painful subperiosteal hemorrhage involving the long bones. Okay. So that is the clinical feature that you get in scurvy. Now moving ahead, we have a child's height for age is less than -2 standard deviations. The child will be classified under which of the following categories? So is it wasting, or normal, or stunting, or severe acute malnutrition? Okay, so waiting for your reply. Come on. So very good. Very good, S. Khan, Sharik, Dhruv, Parveen. So it is stunting. So we need to know the WHO classification of malnutrition. So what do we see here? We see the weight for height and height for age. If the weight for height is between -2 to -3 Z-score or between 70 to 79% of expected, then we call it wasting. While if it is less than -3 Z-score or less than 70% of expected, again it is wasting, but it is severe wasting, right? Now, if we look at the height for age, as was given in this question, if the height for age is between -2 to -3 Z-score or between 85 to 89% of expected, it is stunting. While if it is less than -3 Z-score or less than 85% of expected, then it is severe stunting. And if there is edema, you add the word edematous in front of the name of that category. Edematous wasting or edematous stunting. Now friends, remember, decrease in height for age is always a feature of chronic or long-standing malnutrition, while decrease in weight for height or wasting is a feature of acute malnutrition. Okay, right? Okay. So Atif, you are asking about kangaroo mother care. Yes, of course, mother as well as the baby should be hemodynamically stable. Obviously, then the mother can do kangaroo mother care for the baby. But you know, if the kangaroo mother care can also be done by a father or any other relative also, at least the skin to skin contact part can be done. But of course, exclusive breastfeeding will not be possible at that time. Right. So moving back, for severe malnutrition, mid-arm circumference will be less than. So we need to know the definition of SAM. So how do you define SAM to answer this question? So SAM or severe acute malnutrition, n number of times it has come as, you know, a question. So in a child between 6 months to 5 years of age, severe acute malnutrition is defined as presence of one or more of. So what are they? Weight for height less than minus 3 standard deviations or Z score, or less than 70% of expected. Okay, that means severe wasting. Okay, or if there is presence of mid-arm circumference less than 11.5 centimeters, or there is presence of symmetric bipedal edema of nutritional origin. Symmetric bipedal edema of nutritional origin. So you are getting edema and there is no other cause for edema like nephrotic syndrome or any other cause. So symmetric bipedal edema of nutritional origin, then you call it SAM. Okay, right? So moving back to our question, right? So I'm sure all of you have answered it correctly. So severe acute malnutrition, mid-arm circumference will be less than, it is 11.5 centimeters. And we all know for mid-arm circumference, measuring it, the field workers are going to use Shakir's tape, right? Which is a tape with red, yellow and green zones. Okay, so moving ahead to this question in June 2022. So don't get bogged down by the questions which appear to be relatively long. Trust me, they are very, very simple if you get the hang of it. So a 3-year-old child presented to OPD with his mother, and his mother reports exclusive breastfeeding till 2 years of age. So we want exclusive breastfeeding till 6 months. Exclusive breastfeeding is not recommended till 2 years. Okay, beyond 6 months, what is recommended is complementary feeding should be started in addition to breast milk. Breast milk can be continued till 2 years, but not exclusive breastfeeding. Okay. If exclusive breastfeeding is done till 2 years, then the child will be malnourished, because beyond 6 months, breast milk is not sufficient to meet the needs of the child. Yes, so I can already see the answers coming. Muzammil, Nivedita, Himanshu, Priyanka, Umair, very good. So now the child has decreased appetite. On examination, malnutrition was found along with edema. So when you're getting malnutrition with edema, our diagnosis becomes kwashiorkor. Okay. So there is this Wellcome Trust classification, another classification of malnutrition, where we see the weight for age. If the weight for age is 60 to 80% of expected, edema is absent, then it is just called undernutrition. Okay, undernutrition, there is no special name for it. However, if the weight for age is 60 to 80% of expected but edema is present, then we call it kwashiorkor. So malnutrition with edema, we call it kwashiorkor. If the weight for age is severely low, so if it is, less than 60% of expected and there is no edema, then we call it marasmus. Okay, we should be aware of these terminologies. While if the weight for age is less than 60% of expected, but the edema is also present, then we call it marasmic kwashiorkor. So features of marasmus also there, features of kwashiorkor, that is edema also there, right? So if you get a picture of a totally emaciated child without any edema, then think of marasmus. But if edema is present, think of kwashiorkor. So true regarding the image given below. So here we can see a malnourished child with, you can see the abdomen is distended, the limbs are edematous. Okay, the limbs are swollen. Okay, abdomen is distended and limbs are swollen. So this is a case of kwashiorkor. And we all know kwashiorkor is, yes, come on. Very good. I can see Umair, Kalepu, Sharik. Very good. So we know kwashiorkor is predominantly due to less protein intake. Okay. So lot of questions you get from nutrition and malnutrition. So we need to be aware of it. So kwashiorkor, we all saw edema is present in kwashiorkor, but it is absent in marasmus. What else? So if you look at appetite, okay, appetite is poor in kwashiorkor. The child does not want to eat anything, but appetite is good, voracious in marasmus. Child wants to eat anything that comes in front of the child. Okay. What else? So in kwashiorkor, the child has got, so CNS involvement is there in kwashiorkor. So the child has apathy or lethargy. The child is not interested in surroundings. While in marasmus, the child is active and alert. Okay. Hepatomegaly. So fatty hepatomegaly, fatty enlargement of liver or fatty hepatomegaly is present in kwashiorkor, absent in marasmus. And skin and hair changes of malnutrition. Skin and hair changes are more common in kwashiorkor than marasmus. What are the skin changes? So it is the flaky paint dermatosis. What is the hair change that you get in malnutrition? It is the flag sign. Okay, flag sign, alternate bands of pigmented and hypopigmented hairs, right? So of course, marasmus has a better prognosis than kwashiorkor. Now, what is the fluid of choice for shock in a child with severe acute malnutrition? Now, otherwise, for shock in children, okay, otherwise if there is no malnutrition, okay, then the fluid of choice for shock in children is normal saline. But fluid of choice for shock in a child with severe acute malnutrition, very good. I am really impressed. Rahul, Roshan, Aditya, Kalepu Andrews. So it is ringer lactate with 5% dextrose. So fluid of choice for shock in a child with severe acute malnutrition, then our choice becomes RL in 5% dextrose, because we don't want hypoglycemia again to happen. While if you get a case scenario like this that you got in June 2021, that a boy presents with features of shock and cold clammy skin, you don't know, the malnutrition part is not mentioned. Okay, so we assume it is the otherwise well child who presented with features of shock, cold clammy skin. Then of course we will go with Parveen, Aditya, Vikrant, very good, IV normal saline. And if we are suspecting septic shock, we will also start antibiotics. So we will give IV normal saline boluses and start antibiotics. Now, a child presented with vomiting and dehydration, ABCDE was performed. What does D stand for? Now, any child who is a sick child and presents in the emergency, you have to do an initial assessment which is ABCDE. So, A stands for, we all know A stands for airway, B stands for breathing, C stands for circulation, D stands for very good, Baisla, Ajay, Roshan, Ashish, Umair, Ayaz, Chandni, Faiz. I'm sorry if I'm missing on some names. So D stands for disability. Okay, disability. That means any neurological abnormality if the child is having. And E is for exposure. That means you expose the child properly and look at what is the situation. So D is for disability here. And this question, friends, you can see has been repeated in Jan 2023 also, June 2022 also, and prior to that also once. Right? Right. So which of the following has autosomal recessive inheritance? So friends, we need to know certain disorders which are, which are having autosomal dominant inheritance, and the important disorders that have autosomal recessive inheritance. Hereditary spherocytosis, we all know, has autosomal dominant inheritance, while sickle cell anemia has got autosomal recessive inheritance. Osteogenesis imperfecta, most of the types have autosomal dominant inheritance. Von Willebrand also autosomal dominant inheritance. So your question is which of the following has autosomal recessive inheritance? So our answer here becomes yes, Avdesh, Roshan, Dipanjali. So it is sickle cell anemia. So how do we remember important autosomal dominant diseases? We can remember by the mnemonic heavy dominant. So H for hereditary spherocytosis, V for von Willebrand disease, D for dystrophia myotonica, O for osteogenesis imperfecta, M for Marfan, where a child is really tall and has got a lot of skeletal abnormalities, lens dislocation of the eye. I for intermittent porphyria, N for neurofibromatosis, where you can get capriolet spots, Lish nodules in the eyes, and so on. A for achondroplasia, where you will get a short stature, autosomal dominant polycystic kidney disease, and for Noonan syndrome, and T for tuberous sclerosis. Right? Some important autosomal recessive disorders, just you can remember by A, B, C, D, E, F, G, H, I. So A for albinism. So remember, most of the inborn errors of metabolism are autosomal recessive, barring a few exceptions. Okay. So most of the types of mucopolysaccharidosis again are autosomal recessive except type 2 or Hunter disease. So B for beta thalassemia and other hemoglobinopathies like sickle cell anemia. C for cystic fibrosis, and CAH, congenital adrenal hyperplasia. Again, you get questions on this. This is most commonly due to 21 hydroxylase deficiency. Right? D for deafness. E for emphysema, which is due to alpha-1 antitrypsin deficiency. F for Friedreich's ataxia. G for Gaucher galactosemia. Okay, H for homocystinuria, I for inborn errors of metabolism. We said most of the inborn errors of metabolism have autosomal recessive inheritance except Fabry disease, which is X-linked. Okay, Fabry disease, which is X-linked. Right? So moving ahead to another similar question. December 2019, it was asked which of the following is an autosomal dominant disease. So we all know von Willebrand disease is autosomal dominant, while Wilson's has autosomal recessive inheritance, cystic fibrosis also recessive, and Friedreich's ataxia also recessive. Right? So von Willebrand disease is the answer here. Now moving ahead, again a similar question. Now they've replaced it with a case scenario, but they are asking the same thing. I've just put this question again, June 2022, to show you despite the case scenario, the questions that they are asking are still very, very easy and very, very basic, and you can really score on it. So child presents with Lish nodules on iris and capriolet spots. So what is our diagnosis here? Of course, it is neurofibromatosis. And you are getting similar symptoms in his father and grandmother also. So you can see vertical transmission is also happening. And neurofibromatosis, friends, we all know is a classical example of autosomal dominant inheritance. Right? So our answer here is B. Very good. Shubham, Aditya, Mittu, Deepak Sharma, Parveen. Right? A 16-year-old girl presents with short height. Okay. Primary amenorrhea, that means her menarche has not yet been attained, so delayed puberty is there. Widely spaced nipple, her probable karyotype is. So in a girl with short stature, primary amenorrhea, widely spaced nipples, So we will think of Turner syndrome, and we all know the karyotype picture in Turner syndrome. What do you get in karyotype on Turner syndrome? So very good. The answer is A. Kaushal, Gerald, Shubham, Lovely, Poison. Oh my God, the names that you keep. So A 45XO is the right answer here. So you can see the karyotype picture here. If you count the total number of chromosomes here, you can see that total there are 45 chromosomes, and you can see there is one X chromosome and there is no Y chromosome. So your this karyotype picture is 45. So total number of chromosomes here is 45, and XO means single X chromosome, no Y chromosome. So that is Turner syndrome, the karyotype that you get. Okay. Now, a child with hypoglycemia was found to have burnt sugar urine odor. Which enzyme is deficient? So burnt sugar urine odor, friends, we all know we get in MSUD, maple syrup urine disease. And the enzyme deficient is branch chain alpha keto acid dehydrogenase. Very good. Lovely, Rajendra, Atif Aslam. Right. So there are certain inborn errors of metabolism with peculiar odor. Like glutaric acidemia, you get a sweaty feet odor. Okay, sweaty feet odor. Maple syrup urine disease, you get a burnt sugar odor, like we already mentioned. So burnt sugar odor. Tyrosinemia, you get a boiled cabbage kind of odor, boiled cabbage odor. Okay, sometimes you get questions related to it. Multiple carboxylase deficiency was asked one, tomcat urine odor. And phenylketonuria, you get a mousy or a musty body odor. Okay, right? Now, a child will again this question has been asked multiple times. I've just put the June 2022 one here. A child is brought to the OPD with complaint of change in the color of urine after some time. Okay, so what is happening is mother gives a history that she noticed a dark black color on diaper when her baby was few months old. Which enzyme deficiency is present? So urine turns black on standing. Classical of what disorder? So it is alkaptonuria. And what enzyme is deficient? We all know it is very good. So it is homogentisic acid oxidase. Hassan, Mehta, and Shubham, you're not right. Kamal, Nivedita. So it is homogentisic acid oxidase deficiency. Now, Koplik spots are seen in. So again, such a simple question. So we all know Koplik spots are, these bluish white spots with erythematous border. They are seen on buccal mucosa, but can be seen in conjunctiva and vagina. So they are classical of measles, pathognomonic of measles. Very good. Parveen, Aditya, Rahul, Roshan. Again, subacute sclerosing panencephalitis is a rare and dangerous complication of. So again, the answer here remains measles. So we all know a long-standing complication which can happen 7 to 10 years later after a measles infection is subacute sclerosing panencephalitis. So measles is very, very important, friends. You see in Jan 2023 also you got a question on measles. So 5-year-old child develops a fever with rash, also had cough, conjunctivitis, coryza, this wet kind of a look that this child is having. So maculopapular rash is there. So again, our diagnosis here is measles, right? Okay, very good. So measles, we get this erythematous maculopapular rash. Okay, erythematous maculopapular rash with coryza, conjunctivitis, and so on. Chickenpox, what do you get? Chickenpox, you get pleomorphic rash. That means different types of rash at the same time. So you get macules also, papules also, vesicles also, pustules also, all at the same time. Think of chickenpox. Erythema infectiosum, you get a slab cheek appearance of the rash. And hand, foot, mouth disease, you get blisters with a erythematous rim, which will then move on to become superficial ulcers. Okay. Now, so this, friends, again, you have a question in December 2021, 18-month-old child, runny nose, fever, and on examination, you can see this characteristic slab cheek rash. So slab cheek rash is suggestive of erythema infectiosum, which is caused by parvovirus B19. Okay. So a male child presents to you with fever and swelling below the ear, so in the parotid region, with no other systemic manifestations. There have been 2 other similar cases in the friends of the child in the same village. What will you do? So this, friends, what is your diagnosis here? First tell me. So what is your diagnosis here? So no, unfortunately, we are not going to do immediate hospitalization. Incision and drainage is also not required. Parveen, you're right. And Chandani, you are also right. So this is a case of mumps. So there is fever and swelling in the parotid region and no other features. Okay. And it is such an infectious disease that 2 other similar friends also have this illness. So it is mumps. It is a viral illness. It is a self-limiting illness. Hospitalization is not required. Incision drainage is not required. Mouthwashes are not going to help. Just give antipyretics only. That is the best answer. Right? Which vaccines are given at birth? So we all know the vaccines given at birth are BCG, OPV birth dose and hepatitis B birth dose. MR is not given at birth, DPT not given at birth. Okay, IPV, DPT not given at birth. So BCG, OPV and Hep B birth dose. So national immunization schedule, just a quick revision. So at birth you have the which vaccines? So BCG, OPV 0 dose and hepatitis B birth dose. These are the vaccines given at birth. At 6 weeks, 5 vaccines are given. What are those? 2 oral vaccines, 3 injectable vaccines. So 6 weeks you have 2 oral vaccines, OPV and rotavirus vaccine. These 2 are oral. And 3 injectable vaccines, what are they? Pentavalent first dose, fractional IPV first dose, pneumococcal conjugate vaccine first dose. Okay. 10 weeks you have 3 vaccines, the OPV second dose, rotavirus second dose, pentavalent second dose. 14 weeks, again you have those 5 vaccines which you had at 6 weeks. So what are those? OPV third dose, rotavirus third dose, pentavalent third dose, fractional IPV second dose and pneumococcal vaccine second dose. Okay. Then 9 to 12 months you have the MR1, the measles rubella vaccine. Remember, measles vaccine, if you have given before 9 months, it is not counted. It must be given only after completed 9 months. Okay. And PCV booster, Japanese encephalitis 1, and very recently an additional dose of fractional IPV is now recommended at 9 months. Okay, from this 1st January 2023. So additional dose of fractional IPV has been added at 9 months. Okay, so MR vaccine, PCV booster, Japanese encephalitis in endemic areas and fractional IPV third dose. 16 to 24 months you will give the second dose of MR vaccine, DPT booster, OPV booster, Japanese encephalitis second dose in endemic areas. 5 and 10 years you give the, so 5 years DPT booster and 10 years you give the TD vaccine, 10 years and 16 years. So these are the vaccines in the national immunization schedule, a must know topic. See, you got so many questions from it. Which of the following vaccines is recommended at birth? So easy. At birth, which vaccine you will give? You will not give measles, JE, vitamin A, so it is BCG, right? First dose of measles vaccine was given on, so first dose given on 7 months of age due to some reason. When will you schedule the next dose? So we already specified, even if you have given measles vaccine earlier, that dose is not counted. The first dose that you will count is the dose that is given at 9 completed months. So your best answer here is going to be, no friends, it is not C. So the best answer for this measles vaccine question, so first dose given at 7 months of age due to some reason, when will you schedule the child for next dose? So we will not count the 7-month wala dose. We will give again a first dose at 9 months and the next at 16 to 24 months. So this is the best answer. Okay. So first dose at 9 months, next at 16 to 24 months. Right. Mukesh, Mittu, very good. So hepatitis B vaccine should be given. So we don't recommend at 3 months, 6 months or 1 year in the national immunization schedule. In national immunization schedule, it is given at birth and as a part of pentavalent vaccine, it is given at 6, 10 and 14 weeks also. Okay. Protection given by yellow fever vaccine is valid for. So as per the latest recommendation, the protection given by yellow fever vaccine starts from 10 days after vaccination and it is valid for lifelong. Very good, Roshan, Vikash, Karishma, Shubham, very good. Okay, so we all know yellow fever vaccine is a live attenuated vaccine. The 17D strain grows in chick embryo cells. So in egg allergic patients, we don't give it. Diluent sterile saline and you have to use it within 1 hour of dilution. Subcutaneously it is given and the certification of vaccination is valid lifelong for those of you who plan to go abroad. Okay, again, of course. So 2 open vials of pentavalent vaccine and 1 open vial of MMR vaccine is given back after an immunization session. So you have these open vials of pentavalent vaccine and MMR vaccine is given back after an immunization session. What should be done with those vials? Both should be discarded. Pentavalent can be used, MMR discarded. MMR used, pentavalent discarded. Both vials can be reused. So this, friends, clearly is a question on open vial policy. So first let us see what is the open vial policy, and by the way you all are right, the answer is pentavalent can be used and MMR must be discarded. Let us discuss a little bit about this open vial policy. So this open vial policy promotes the reuse, reuse of partially opened, reuse of partially opened multi-dose vials of certain vaccines, partially, so reuse of opened and partially used, partially used multi-dose vials. So if you have a vial which has 10 doses of certain vaccine, you have used only 2 doses in an immunization session. If the vaccine follows open vial policy, you can reuse the remaining doses in the next session. Okay, so that is the whole purpose of this open vial policy. Okay, So open vial policy, to follow this, what all things you have to check? There should be a readable and intact label. The VVM, vaccine vial monitor, should show usability. Expiry date should not be passed. The vaccine should not be frozen. And if the vial is already open, we have to see septum should not be leaking. Date and time of opening of the vial should be mentioned, because after 28 days you have to discard it. And strict asepsis should be maintained while taking the vaccine out. Okay. Now we all know, again multiple times you've got question on this VVM, which is the vaccine vial monitor. Okay, vaccine vial monitor, even the full form is important. So if the vaccine vial monitor shows the inner square is lighter than the outer circle, you can use this vaccine. But if the inner square is same color or darker color, you cannot use the vaccine. So this shows the heat damage or thermal damage to the vaccine. Now, which vaccines follow open vial policy, which do not? So there are only 4 vaccines that do not follow the open vial policy. Which vaccines do not follow the open vial policy? Remember, BMRJ. Okay, B is for BCG, M is for measles or MR vaccine, R is for rotavirus vaccine, okay, and J is for Japanese encephalitis vaccine. So these vaccines do not follow the open vial policy. Rest all vaccines follow it. So pentavalent follows open vial policy, but these vaccines BMRJ does not. Okay. Which vaccine doesn't follow open vial policy? You can see such a straightforward question in June 2021. So we all know BMRJ does not follow. So BCG does not follow the open vial policy. Rest of the others follow it. Now, a primary gravida patient came to the hospital without any antenatal checkup at 37 weeks of gestation and presented with the onset of labor. On investigation, the mother is hepatitis B positive. What is the management of the neonate? Whether you will give hepatitis B vaccine only, or vaccine plus immunoglobulin, or first immunoglobulin then hepatitis B vaccine after 1 month, or only immunoglobulin. So what is your best answer? So very good, lovely, Kavya, Abhishek, Parveen, Rakesh, Abhishek, Sharik. So you will give hepatitis B vaccine plus immunoglobulin at birth only, within 12 hours of life, as soon as possible. So you will take hepatitis B vaccine and hepatitis B immunoglobulin in different injections, give at different sites intramuscularly as soon as possible after birth. So they give the best protection. Only if immunoglobulin is not available, then you will give vaccine alone. So hepatitis B vaccine plus immunoglobulin should be given in a hepatitis B positive mother to prevent the transmission. What we have here is a child who presents with abdominal pain, hematuria, and palpable purpura over the leg. His skin lesions show IgA deposition on biopsy. What is the diagnosis? Whether it is ITP, henoch-Schönlein purpura, acute leukemia, or post-streptococcal glomerulonephritis. So, very good. So, Rakesh, Tanay, Parveen, antidote. Okay. So, this is henoch-Schönlein purpura. So, you know, wherever you are getting a palpable purpura with any one of the following, abdominal pain or arthritis, or any evidence of kidney involvement or any IgA deposition, think of henoch-Schönlein purpura. Thrombocytopenia is not a feature of this HSP. Okay. Now moving ahead to some questions from neonatology. Very, very simple questions that have come. So a post-term neonate is a neonate that is born. So a neonate is called post-term if a baby is born beyond 42 weeks. Okay. Baby born before 37 weeks of gestation is a preterm neonate. Post-term is beyond 42 weeks. Okay. So what is a small for gestational age baby or small for date baby? So small for gestational age or small for date baby is a baby whose birth weight is less than 10th percentile of expected. Less than 10th percentile of expected according to the gestational age. Okay. According to the gestational age. Right. All are the signs of adequate breastfeeding in a 2-month-old infant except. So adequate breastfeeding is seen if the baby, you know, when do you call it adequate breastfeeding? When the baby sleeps for 2 to 3 hours after feeding, yes. Urinates 6 to 8 times a day, yes. Gains weight, yes. Has normal hemoglobin level, no. So breastfeeding has nothing to do with normal hemoglobin level. So all are the signs of adequate breastfeeding except. Please do read this except, okay? Don't jump and mark the answer as A. Please read the word except, and so our answer comes to be D, as most of you have answered it correctly. Very good. So answer here is D. Identify the abnormality in the following X-ray of a newborn with respiratory distress. So what you can see here, you can see the bowel loops in the thorax here. You can see that the heart shadow has shifted to the opposite side. So this is the right side, this is the left side. You can see the heart shadow is shifted to right side, and you can see the bowel loops in the thorax. You can hardly see any lungs. So this is a classical X-ray of congenital diaphragmatic hernia. And if CDH is present, remember bag and mask ventilation is absolutely contraindicated in congenital diaphragmatic hernia. That is another important question, right? So which drug is preferred in premature neonates for closure of PDA? So to close PDA in premature neonates, you have to give prostaglandin inhibitors. You can give ibuprofen, you can give indomethacin. Mefenamic acid is not used. Alprostadil is used to keep the ductus arteriosus open and not close it. So out of ibuprofen and indomethacin, ibuprofen has got lesser side effects. So the preferred choice would be ibuprofen here, right? A neonate is unable to open the eyelid. Identify the condition given. You can see here a patch here, reddish colored. So this is a case of capillary hemangioma. Mongolian spot appears as bluish black lesions in the buttock area mainly. And melia are colorless papules. Erythema toxicum are some erythematous maculopapular lesions mainly on the trunk. Okay. So, according to neonatal resuscitation protocol, chest compression is initiated at heart rate below, whether it is 80 per minute, 75, 70 or 60. Waiting for your answers. Meanwhile, a quick recap of the neonatal resuscitation protocol. We start with antenatal counseling, team briefing, equipment check. Then the baby is born. If everything is fine, term gestation, good tone, breathing or crying, then the baby gets routine care. If anything is abnormal, then you stimulate the baby. Then you see if the apnea, gasping or heart rate less than 100 per minute, start positive pressure ventilation. And if the heart rate is less than 60 per minute, then you start chest compressions along with positive pressure ventilation, right? So our answer for this question, so as all of you have answered correctly, Ayaz, Aisha, Lovely Poison, Paras, Raju, Nivedita, it is less than 60 per minute, right? So below 60 per minute, you have to start chest compressions. And if that also, if it is not improving, you have to give IV epinephrine, okay? Now, according to the neonatal resuscitation protocol, how much oxygen to be given to a term neonate with apnea and bradycardia initially? So initially, whenever you are doing positive pressure ventilation with bag and mask in a term baby, we start with room air, okay? So how much oxygen concentration? So we start with, very good, Andrews, Roshan, Hitesh, we start with 21%. Only if the baby is not improving and we have to give chest compressions also, then we give 100% oxygen. Now, a baby was born limp and having apnea. So if there is apnea, what do you start with? Straight away, will you start with chest compressions or give oxygen or do umbilical vein catheterization or bag and mask ventilation? Very good, Bharat. So we will go ahead with bag and mask ventilation or positive pressure ventilation first. And if the child is having heart rate less than 60 per minute, then do chest compressions and give oxygen along with it. Okay. Umbilical vein catheterization is required if you're planning to give epinephrine if the baby is not improving even with chest compressions. Now, vitamin K is given at birth to prevent. So, of course, again, no points in answering this question. Very, very simple, straightforward question. So, vitamin K is given at birth to prevent this hemorrhagic disease of newborn, which is also called vitamin K deficiency bleeding. Very good. Right. Infant of diabetic mother is at increased risk of development of which of the following? Hypoglycemia or hyperglycemia because it is diabetes, or anemia or diarrhea. Again, it is a pretty straightforward question. We all know infant of diabetic mother, more risk of development of, very good, Divya, Jyoti, Bharat, Kavya and Paras. So hypoglycemia is the best answer here. So apart from hypoglycemia, hypocalcemia and hypomagnesemia that can happen in infant of diabetic mother, in CVS more chances of congenital heart diseases, most specific being TGA or transmission of great arteries and most common being VSD. Also asymmetric septal hypertrophy is common in these babies. Among the neurological findings, you can get sacral agenesis or caudal regression syndrome, which is most specific, while most common being neural tube defects. Amongst renal, you can get hydronephrosis or you can get renal agenesis, okay, renal agenesis or renal vein thrombosis, okay. GI, you can get duodenal atresia. And long-term complications can happen in the baby when the baby grows up. The baby can have blindness, obesity and diabetes. Okay, when the baby grows up, right? So many problems are possible in infant of diabetic mother. Moving on to some important topics from systemic pediatrics, which are a must know. So a pregnant lady with mood disorder was on lithium for her psychiatric issues. The baby was born through a previous pregnancy, had Down syndrome. The child born with which of the following abnormalities? The child can be born with which of the following abnormalities due to maternal lithium intake? So, you know, the drugs that the mother are taking in pregnancy has a bearing on the baby also. So, very good, Rajendra, Rahil, Hassan, Krishan, all of you are right. So, Epstein anomaly can develop because of the lithium intake in the mother. So, some of the important drugs which have some effect on the baby. So, if the mother takes during pregnancy, so if the mother takes lithium during pregnancy, the baby can have Epstein anomaly as we mentioned. So, Epstein anomaly and macrosomia or large forehead baby. If the mother is on alcohol during pregnancy, baby can have fetal alcohol syndrome, where there can be some CNS abnormalities, there can be dysmorphism in the baby. Okay, there can be microcephaly. Okay, microcephaly can be there, and there can be congenital heart diseases, limb abnormalities, and so on. Warfarin, if the mother is on warfarin, the baby can have bleeding. Okay, bleeding tendency, and hypoplastic nose. The nose is not well formed. Okay, hypoplastic or depressed nose can be there. Okay, fetal warfarin syndrome, again it is called. Carbimazole. Okay, if the mother is on carbimazole, an anti-thyroid drug, then the baby can have scalp defects. Okay, scalp defects, choanal atresia, esophageal atresia. Choanal atresia and esophageal atresia. Okay. If the mother is on carbamazepine, an anti-epileptic, the baby can have neural tube defects. If the mother is on thalidomide, the baby can have limb defects, which are called phocomelia. Okay, phocomelia can be there and deafness can be there. Okay, and vitamin D, if the mother is on vitamin D, the baby can have hypercalcemia and aortic stenosis also, right? So very, very important. The effect of maternal drugs on the baby when the drugs are taken during pregnancy. Okay. Now, a 5-year-old child. So recently, nowadays you're getting some questions on poisoning also, childhood poisoning. Do read that up. So a 5-year-old child who has taken 10 iron tablets, presents with nausea and abdominal pain. What is the antidote of iron poisoning? So it has to be an iron chelating agent. And we know from our knowledge of thalassemia, the iron chelators in thalassemia, penicillamine, triantine and zinc are all copper chelators which are used in Wilson disease. Copper chelators used in Wilson disease. Desferrioxamine is an iron chelator. Very good. Sajal, Mittu, Prakhar, Sonu, Vikas. So drugs used for iron chelation in thalassemia, we all know desferrioxamine is the one which is used parenterally. Okay, parenterally. And apart from that, you have the oral drugs which are deferriprone and deferasirox. Deferasirox. Right? Moving ahead, a 3-year-old child, okay, with diarrhea for 2 days was irritable and extremely thirsty. There was no history of vomiting. What is the next step? So a child with diarrhea who is irritable, extremely thirsty, this child has got some dehydration. Okay, some dehydration. And for some dehydration, you will not give normal saline or ringer lactate. We will give oral rehydration solution. Unless, of course, if the child has, severe vomiting, then we have to give IV. So oral rehydration solution, as told by you, Rahil, Ashish, Abhishek, Gerald, Mehta, is the correct answer. So how to assess dehydration in a child with diarrhea from a given case scenario? Very, very important. So look at the sensorium. If the sensorium, the child is well and alert, active and alert, no dehydration. In some dehydration, what will happen? The child will be restless and irritable. Restless and irritable. Severe dehydration, the child will be lethargic and floppy. Okay, lethargic. Okay, and floppy. Totally limp. Eyes may be normal in no dehydration, sunken in some dehydration, very sunken in severe dehydration, and dry also. Tears normally present but absent in some and severe dehydration. Mucosa is moist in no dehydration and it is dry and very dry in severe dehydration. Thirst. The child drinks normally and is not thirsty. Okay, drinks normally in no dehydration. But in some dehydration, what happens? The child is thirsty and drinks eagerly. So thirsty, extremely thirsty and drinks eagerly. Then you think of some dehydration as in the current scenario. Okay. And while in severe dehydration, the child is not able to drink. Not able to drink. Right. Skin pinch goes back normally. Okay. Or quickly in no dehydration. Slowly in some dehydration. Very slowly, taking more than 2 seconds in severe dehydration. So, 3 most important things are STS, sensorium, thirst and skin pinch. So, you look at the sensorium in our given question, the child is restless, irritable and thirsty and drinks eagerly. So, it is some dehydration. So, you have to qualify whether it is no dehydration, some dehydration, severe dehydration. Okay? Right. So, treatment of dehydration in a child with diarrhea will be based on the category. No dehydration, you still give ORS 5 to 10 ml per kg per loose stool. Okay? To replace the ongoing losses. In some dehydration, what will you do? You will give 75 ml per kg ORS over 4 hours. Severe dehydration, you are going to give 100 ml per kg. Right? This 100 ml per kg in severe dehydration, first 30 ml per kg in less than 1 year, you give over 1 hour. Next 70 ml per kg over 5 hours. So total 100 ml per kg in a child less than 1 year of age, you will give over 6 hours. While in a child more than 1 year of age, you will give first 30 ml over half an hour. Next 70 ml over 2.5 hours and total over 3 hours. So remember, correct severe dehydration in a child less than 1 year of age in 6 hours. more than 1 year of age in 3 hours. Okay. So acute diarrhea in children, what will you do? You give WHO, ORS. You have to start zinc therapy, and continue normal diet. So acute diarrhea, no need to restrict milk or any other thing. Continue normal diet. Okay, that is the treatment of acute diarrhea in children. Composition of WHO ORS, again friends, very important. Sodium and glucose both are 75. Citrate is 10, chloride 65, potassium 20. So the osmolality of the WHO ORS is 245 milliosmoles per liter. Okay, so that is important. Now, what we have here is again another long question, but very, very simple. A 3-year child who presented with recurrent episodes of diarrhea. Okay, so just give me a moment. My laptop battery is running low. I'll just plug in the charger. Just give me a moment, guys. So we are good to go. Sorry for the interruption. So what we have here is a 3-year-old child who presented with recurrent episodes of diarrhea and abdominal distension. And on examination, he was found to have anemia, short stature, and failure to thrive. So anemia, short stature, failure to thrive, recurrent diarrhea, abdominal distension. What else do you need to call it? Celiac disease. And of course, upper GI endoscopy along with duodenal biopsy revealed villus atrophy. So this, of course, friends, is a case of celiac disease. Very good. So you have to give gluten-free diet for this child. Okay. So moving on to the next question. A child was brought with history of frothiness from mouth and respiratory distress. X-ray of the child is shown below. What do you see in the X-ray? So can you appreciate a structure which is like this, coiled here? So this is a feeding tube which is not getting passed inside to the stomach. So there is coiling of feeding tube in the upper part of the esophagus. So this is esophageal atresia with tracheoesophageal fistula, right? So very good, Siddharth Modi, you answered it correctly. Sonu Sharik, proud of you. So esophageal atresia with tracheoesophageal fistula which requires immediate surgery. Most common cause of inspiratory stridor in an infant is. So in otherwise well infant, if you're getting inspiratory stridor, think of laryngomalacia. And this stridor increases on feeding and crying, decreases in prone position. Self-limiting condition, no treatment required. A 7-year-old immunized child presents with thumb sign on X-ray. Which organism is most commonly responsible? So thumb sign on X-ray is a feature of acute epiglottitis. Now previously the most common organism responsible for acute epiglottitis was H. influenzae. But now with the H. influenzae vaccination being a part of the pentavalent vaccine, H. influenzae is no longer the commonest organism. The commonest organism now is, lovely poison is right, Stalin also, so it is Streptococcus. Okay. Streptococcus. So H. influenzae is not the correct answer. Now in vaccinated populations, Streptococcus is the best answer. Okay, parainfluenza virus we know is the cause for croup and influenza virus is not the answer here. So you can see this thumb sign in epiglottitis and you can see here the narrowing of the airway just like the steeple of a church, and that is seen in croup or acute laryngotracheobronchitis. Okay. Now, croup we know is a viral illness which is caused most commonly by the parainfluenza virus, right? While acute epiglottitis is a bacterial illness most commonly caused by Streptococcus in immunized population. In unimmunized population, it can still be caused by H. influenzae. So, croup, it is a viral illness, so the child will have low-grade fever and there can be some coryza and cough and stridor, okay? But the child is usually not very sick. While in acute epiglottitis is a bacterial illness, so the child will have high-grade fever, okay? High-grade fever will be there, right? And drooling of saliva, the child will not be able to swallow his own saliva. So it is a very, very severe condition. Acute epiglottitis is a very severe condition, right? X-ray picture we already saw. Croup, you got the steeple sign. Acute epiglottitis, we got the thumb sign. Treatment. In croup, it is a viral illness, so it is mainly supportive care plus dexamethasone, oral or injectable dexamethasone, that is steroids. And in severe cases, you can give adrenaline nebulization, ADR nebulization. Okay. What about the acute epiglottitis? It is a bacterial illness, so you have to give IV antibiotics. Okay, IV antibiotics. So very good, Aditya. So in croup, you are not going to give any antibiotics. Okay, no antibiotics in croup, right? So there comes the genesis of another question that was asked in the June 2022 exam. Again, a child with difficulty in breathing had steeple sign. That means the diagnosis is croup. There was low grade fever and stridor only on crying. What is the treatment? So is it antibiotic with steroid on oxygen? No, we do not want to give antibiotic in croup. Oral steroid? Yes. Antibiotic, cough suppressant, decongestant? No. Reassuring the patient only will not help, right? So we know the best answer here is oral steroid. Okay. Very good. Now, Sheen, Hitesh, Ajay. So next we have a 2-year-old child who presented to the primary health center. Okay, primary health center with complaint of cough and difficulty in breathing. On physical examination, chest indrawing was present with respiratory rate of 38 per minute. How would you classify this child? What should be the next step of management? Whether it is severe pneumonia, start IV antibiotic, moderate pneumonia, treat in the clinic, pneumonia, give oral antibiotic and follow up after 2 days, no pneumonia, cough and cold only. So let us first discuss a little bit about the IMNCI guideline here and then come back to answer this question. So to simplify the IMNCI guidelines. So you have to see 3 things, okay? Whether fast breathing, so you have to see whether fast breathing or chest indrawing is present or not. Okay? And you have to see whether any general danger sign is present or not. General danger sign is present or not. Okay? So if fast breathing or chest indrawing is not present, general danger sign is also not present. Okay, fast breathing, chest indrawing not present, general danger sign also not present, then it is called no pneumonia, cough and cold only. Okay, no pneumonia, cough and cold only. Cough and cold only. Okay. Now if either fast breathing or chest indrawing is present, okay, either fast breathing or chest indrawing is present but no general danger sign, then what do you call it? Then you call it pneumonia. Okay. Now, irrespective of whether the fast breathing or chest indrawing is present or not, but if any general danger sign is present, then you call it severe pneumonia or very severe disease. Severe pneumonia or very severe disease. Okay. Now, if there is no pneumonia, then of course no treatment is required, only home-based supportive care. If there is pneumonia, what will you do? You will give oral antibiotics. The child will stay at home, follow up after 2 days. If there is severe pneumonia or very severe disease, give first dose of IV antibiotics and refer. Okay. Now, one more thing before we go back to the question. When do you call it fast breathing? Very, very important, comes as a standalone question also. So, we call it fast breathing in a child less than 2 months age if the respiratory rate is more than 60 per minute. 2 to 12 months if the respiratory rate is more than 50 per minute, and 1 to 5 years if the respiratory rate is more than 40 per minute, right? And what are the general danger signs that you have to look for? So general danger signs that you have to look for are, so general danger signs are, so one is if the child is, having convulsions or seizures, if the child is lethargic, inability to feed, okay, the child is not able to feed, inability to feed, persistent vomiting is there, or an unconscious child. Okay, unconscious child. You can remember this by mnemonic Clivus. Okay, so C for convulsions, L for lethargic, I for inability to feed, V for vomiting, U for unconscious child, and S for stridor in a calm child. Stridor in a calm child. Okay. So if any general danger sign is present, it is very severe disease. If fast breathing is present, it is just pneumonia. Okay, fast breathing or chest indrawing is present, right? Now going back to our question, let us analyze it once again in this light. So here what happens, 2-year-old child, respiratory rate of 38 per minute. So we know it is not fast breathing. Fast breathing would be more than 40 per minute. But chest indrawing is present. So it is pneumonia. And any general danger sign is not mentioned. That unconscious, lethargic, not able to feed, all these are not mentioned. So it is a case of pneumonia and give oral antibiotic, follow up after 2 days, right? So C is the best answer here. Very good, guys, right? So that was about the IMNCI guideline. One more question on this to check whether you have understood or not. Come on, fastest finger first. 3-month-old baby presents with fever and respiratory rate of 68 per minute. He is feeding well, no stridor, no chest indrawing, no convulsion. What is your diagnosis here? So for a 3-month-old baby, the respiratory rate of 68 per minute is fast breathing. There is no chest indrawing, no general danger sign. but fast breathing is present. So your diagnosis here is Ajay, Krishan, Lovely, Hitesh. So it is pneumonia. Very good, right? Because fast breathing is present, right? But no general danger sign. Now, a 6-year-old girl presented with a boil on leg 3 weeks ago and is now presenting with cola colored urine. Cola colored urine, we think of nephritic syndrome. On examination, she was found to have a BP of 138/92. So hypertension, cola colored urine, history of infection a few weeks back. So our diagnosis here is nephritic syndrome and the most common etiology being post-streptococcal glomerulonephritis. Very good. So Raju, Aditya, Naruto, Karishma, Abhishek, Guru, very good. So next we have again a long question, but trust me, very, very simple. So a 5-year-old child presented with edema for last few months. It started on face but is now generalized with pedal edema as well as ascites. He showed good response to steroid. So generalized edema showing good response to steroid, we think of nephrotic syndrome. Okay, and his RBS was 112, which is normal. On urine examination, massive proteinuria, again pointing towards nephrotic syndrome. And on CT examination, the finding was uneventful. Electron microscopy of kidney biopsy, effacement of podocytes. So we know all these are features of minimal change disease, which is the most common cause of nephrotic syndrome in children. All of you are right. Very, very good. Right? So in minimal change disease, light microscopy will be normal. Electron microscopy can show effacement of the foot plate of podocytes. Again, a pretty straightforward question. So generalized edema, massive proteinuria, most commonly seen in, no points in guessing that. So it is of course nephrotic syndrome. So you can see so simple questions also come. Renal agenesis and baby is associated with. So normally vein is 1. So umbilical vein is single. But umbilical arteries are normally 2 in number. But if there is a single umbilical artery, then there are more chances of renal agenesis. Okay, so single umbilical artery is associated with renal agenesis. Which is the most common seizure found in the age group of less than 5 years? So most common cause of seizure in the age group of less than 5 years, is it febrile seizure, tonic-clonic seizure, petit-mal seizure or myoclonic seizure? So I'm sure all of you will answer it correctly. Vikrant, Ehmer, Andrews, Stalin, very good. So the most common seizure found in the age group of less than 5 years is febrile seizures. What is febrile seizures? Febrile seizures is high-grade fever or significant fever along with seizures without any evidence of CNS infection. Only then we call it febrile seizures. Okay, as such, tonic-clonic seizures or petit-mal means absent seizures or myoclonic just, they are not so common in this age group of 6 months to 5 years as is febrile seizure. Right? A 4-year-old child was staring. Okay, so a 4-year-old child was staring and he stopped blinking for a few seconds. Normally you are going to blink very frequently, but if you stop blinking and was staring, that means this is a case of absent seizures. Okay, absent seizures. And what is the drug of choice for absent seizures? So which of the following drug would you like to give for the treatment? So drug of choice for absent seizures, yes. So Lovely, Kavya, Abhishek, Roshan, Mukesh, very good, it is valproate, right? So this is a case scenario of absent seizure, the drug of choice being valproate. For myoclonic jerks also the drug of choice is valproate. Okay. Now, you have a congenital abnormality here, a neonate found to have abnormality involving her head as shown in the image. So guys, what is the abnormality here? I want you to answer. What is the abnormality that you see in the image where the scalp and the cranial bones are absent and the brain is exposed to outside? So what is the abnormality here and what is the embryological basis for this? Yes, so you are right. The failure of closure of anterior neuropore is the answer. But what is the name of this abnormality I am looking for? So Mittu, Mukesh, Abhishek, Muzammil, all of you are right. Sharik, very good. So it is anencephaly. So this abnormality is anencephaly, where that is due to the failure of anterior neuropore. The failure of closure of posterior neuropore would lead to spina bifida. Okay, will lead to spina bifida like meningocele, meningomyelocele and so on. Early closure of neural tube does not have any significance. Premature fusion of cranial sutures leads to a condition called craniosynostosis, where there is abnormality in the shape of the head. Okay, craniosynostosis. Premature fusion of cranial sutures, where there is an abnormality in the shape of the skull or head. Okay, right. Which of the following is true regarding the inheritance of neural tube defects? So neural tube defects, whether it has X-linked dominant inheritance, okay, inheritance of neural tube defects, X-linked dominant or autosomal dominant, multifactorial or X-linked recessive. Yes, waiting for your replies. So X-linked dominant, we know a classical example. Can you give me a classical example of X-linked dominant inheritance? So they are like Rett syndrome. Okay, Rett syndrome or hypophosphatemic rickets. hypophosphatemic rickets. Autosomal dominant, we already saw a list. Heavy dominant, which we said. Multifactorial, yes, so neural tube defect has got a multifactorial inheritance where genetic as well as environmental factors play a role. X-linked recessive are conditions like hemophilia, Duchenne muscular dystrophy. There are some important X-linked conditions where you can get a history that mother's father or maternal uncles have already also been affected, and males are more commonly affected. Okay, so multifactorial is the best answer here. Now, I believe this is our last question, or last but one. A baby was born with neural tube defect. What should have been done to prevent this condition? So this is our last question for the session today. So I want an answer from all of you. So a baby born with neural tube defect, what would be done to prevent this condition? What should have been done? So of course we all know Vikas, Abhishek, Roshan, Rupali, Sonu, Zaved, Stalin, Krishan, Bhavin. Awesome guys. So we should have given folic acid. Now when should we have started this folic acid? When should folic acid be started to prevent neural tube defect? So should you start it when the pregnancy is diagnosed, or when should you start the folic acid? So this folic acid to prevent the neural tube defects should be started at least 1 month before planning the pregnancy. So pre-conceptional period it should be started. So at least 1 month before planning the pregnancy. Okay, before planning the pregnancy it should be started. So before conception, okay, not when the pregnancy is diagnosed, then it will be of no use. Okay, and how much is the dose of folic acid is also important. So in all mothers you give 400, or in all girls of the childbearing age group, you have to give 400 microgram per day. Okay, in all adolescent girls or in the childbearing age group. So you have to give 400 microgram per day in adolescent girls or adults in the childbearing age group. And in high risk women, so high risk women, how much is the dose that you will give? So high risk women, the dose is going to be how much? So 10 times this dose, that is 4000 microgram per day or 4 milligram per day. Okay, 4000 microgram or 4 milligram per day, right? So very, very important, start it before planning the pregnancy, and the dose in all the women it should be 400 microgram per day. High risk women 10 times this dose, friends. So these, friends, were some very, very important MCQs, the previous year's MCQs that have come from pediatrics in your FMGE exams. So these are some very, very important topics, and I really thoroughly enjoyed having this quick revision with you. You guys are awesome, and you had, you interacted so much and you answered almost all the questions correctly barring 1 or 2. So I'm sure guys, all of you are going to do very, very well in the exam. Just trust in yourself, trust in the hard work that you have put in, the hours of toil and preparation that you have put in. So have faith in yourself, have faith in the higher power, and just put in the best. Don't think of the consequences, just put in your best. Okay, try to answer almost all the questions. Okay, don't leave any question because you don't have a negative marking. Don't leave any question. Wherever you have a confusion between any two options, just try to rule out the questions, rule out the options. You have a 50% chance of being correct. So I'm sure guys, all of you are going to you are going to just clear this exam in this go only. My best of the wishes are with you. God bless you. And if you like this video, do like this video and subscribe to our PrepLadder channel. Stay tuned for more such informative videos for you. All the very best guys. Do very, very well, and I'll be waiting to hear your results. Thank you so much. Thank you so much guys.